Good morning, afternoon, or evening, everyone. As you know, my name is Jackie Gordon, and I'm going to discuss with you scope of practice barriers for the clinical nurse specialists. CNSs have essentially been practicing since Florence Nightingale. The essence of CNS practice, as stated by the National Association of Clinical Nurse Specialists, is clinical nursing expertise in diagnosis and treatment to prevent, remediate, or alleviate illness and promote health with a defined specialty population, be that specialty broad or narrow, well-established or emerging. The expertise of clinical practice is manifested in the care of clients, individuals, families, groups, and communities. Florence Nightingale was, in my opinion, the first CNS. She observed and analyzed data to propose that illness and disease were two distinctly different phenomena, and she focused on things other than primary medical issues faced by her patients. Hildegard Paplow is said to be the godmother of the clinical nurse specialist role. In 1965, she published recommendations for graduate preparations as a nurse. She established the first nursing master's degree program focusing exclusively on clinical practice. Graduates of this program were called clinical nurse specialists. By the late 70s and early 80s, literature began to emerge to further define the CNS role. In 1980, the American Nurses Association, in their first edition of the Social Policy Statement, defined a CNS as a nurse who held a master's degree in nursing with a clinical focus. Fast forward to 2015, the National Association of Clinical Nurse Specialists announced its endorsement of the DNP as entry into practice by the year 2030. So what is a CNS anyway? A CNS is an advanced practice registered nurse who works in a variety of specialties to ensure high quality, evidence-based, patient-centered care. As leaders in healthcare settings, CNSs provide direct patient care and lead initiatives to improve care and clinical outcomes and reduce costs. The requirements for a CNS align with the consensus model that state that CNSs must be licensed by their respective state as a CNS, have graduated from an accredited master's program, hold national certification as a CNS, and meet educational requirements, including a minimum of 500 clinical practice hours, and have the 3 Ps, pharmacology, pathophysiology, and physical exam and assessment. As stated previously, NACNS does now support DNP as entry into practice. So, what is my talk about? CNS and prescriptive authority. So while there is consensus on entry into practice as a CNS, title protection and prescriptive authority are left up to the states. The current slide depicts the country and APRN recognition. The text in the picture is the hover for the state of Pennsylvania. As you can see, there are CNSs in Pennsylvania with title protection. However, they are not really considered APRNs. Certified nurse practitioners and CRNAs are truly the only APRNs recognized by the State Board of Nursing, as certified nurse midwives are actually licensed by the Board of Health. This map depicts states that recognize CNS's ability to prescribe medications. As you can see, this practice also varies. Some states allow CNSs to prescribe independently, where others must have a collaborative agreement with a physician. 14 contiguous United States, Hawaii, Alaska, and the Northern Mariana Islands allow independent prescriptive authority for CNSs, and 21 contiguous states and Guam allow non-independent prescriptive authority. So a total of 35 contiguous states, or 70% of the states, allow CNSs to prescribe medications, and an additional 2 U.S. territories and the District of Columbia allow CNSs to prescribe medications in the United States. So this leads me to prescriptive authority in the state of Pennsylvania. There is a national organization interested in moving CNS practice forward, and that is the National Association of Clinical Nurse Specialists. There are also efforts through the National Council of State Boards of Nursing to promote full scope of practice for all APRNs, which NACNS also supports. However, As we all know, practice is dictated by the state in which you reside. The strongest force in the state of Pennsylvania regarding full practice authority, including prescriptive authority for CNSs, is the Pennsylvania State Nurses Association. The PSNA has worked tirelessly to amend the Act of May 22nd, 1951. Yes, that's the last time the law has been revised to practice as a nurse in the state of Pennsylvania. They've worked with state representatives, Steve Baer, who introduced a House Bill 1238 outlining full practice authority for CNSs to include prescriptive authority. This bill was referred to the House Professional Licensure Committee in the 2015 session. This legislative process oftentimes moves at a snail's pace, and this is because it's quite complicated. This is a picture which I first saw when I was at the Student Policy Summit in DC, but it does a really good job of explaining how crazy the road is from a bill to when it actually becomes a law. There are many stops along the way, and it takes a large amount of time. So why do we have barriers for CNS prescriptive authority in Pennsylvania? Pennsylvania has traditionally been a state that is slow to evolve regarding nursing practice. Again, last time it was revised was in 1951, the Nurse Practice Act. In addition, there is strength in numbers. There are currently 10,544 nurse practitioners, 389 midwives, and 215 CNSs in the state of Pennsylvania. So there are many more nurse practitioners. The Pennsylvania Coalition of Nurse Practitioners has worked hard to get Senate Bill 717, introduced by State Senator Pat Vance, and House Bill 765, introduced by State Representative Jesse Trooper. With almost 50 times the number of nurse practitioners to CNSs, NP legislation is much more likely to have a stronger voice and to be passed in the state of Pennsylvania. Furthermore, nursing legislative priorities for the state of Pennsylvania, supported by the Pennsylvania State Nurses Association, are no longer CNS prescriptive authority. They are currently safe staffing, developing the role of a chief nursing officer for the Commonwealth, and nurse delegation. In addition, there are competing priorities amongst groups outside of nursing. The American Medical Association and the American Society of Anesthesiologists are working hard with their political action committee dollars, up to $5.1 million, to encourage legislators not to grant full prescriptive authority to APRNs. They are also not in favor of the DNP degree, as they believe this will cause confusion amongst patients. As depicted in the cartoon, many physicians believe this. However, as a soon-to-be DNP prepared nurse, I desire not to replace a physician, yet to add my knowledge to the care team to provide better outcomes for patients. There has been success with CNS prescriptive authority. Whenever practice barriers are attempting to be moved, facts help. The results of a systematic review undertaken by Newhouse and colleagues, published in 2011, revealed that CNSs improve patient and healthcare outcomes, including decreasing costs and lengths of stays for patients. This type of evidence has aided some states in gaining prescriptive authority. Oregon is an example of a state who successfully worked to achieve prescriptive authority for CNSs. In 2005, CNSs were granted prescriptive authority. This was after many organizations fought to pass Senate Bill 460. This was successful because there was collaboration between state organizations and constant provision of CNS outcomes to lawmakers. As a practicing DNP, there are many ways to address prescriptive authority for CNSs in the state of Pennsylvania. First, contacting my legislators is an important first step. I reside in Lancaster City, so I will contact Representative Mike Sturla to support House Bill 1238. Currently, I am active in my local specialty organization, the Susquehanna Valley chapter of American Association of Critical Care Nurses. There is also a local chapter of NACNS that I can become more active in and attempt to gain support for House Bill 1238 amongst those colleagues. As PSNA has been active in supporting House Bill 1238, however, no longer a priority, I can still also attempt to become active in that organization as well. Apart from organizations, I can speak to the individual CNSs that are employed at my institution to see if they are aware of the legislation and attempt to get them to contact their legislators and support CNS prescriptive authority. Publishing. Publishing evidence that CNSs are providing superior outcomes will help CNSs to gain full practice authority, including prescriptive authority. If we do not publish our outcomes, this is unlikely to occur. So publishing the work that I do on a daily basis and encouraging others to do so can increase awareness about the great work that CNSs do and the improved outcomes that we can provide to patients. Finally, as I recently visited Capitol Hill, this is truly an experience, and in attempting to meet with representatives of Congress can help to move full practice authority for CNSs forward, not only at the state level, but the national level. Thank you for your time. Here are my references, and I hope you have a great day.